Let's get started. I'm Sherry Weinberg, and I'm the president of the Washington chapter of Physicians for a National Health Program. And I want to welcome all of you to our monthly meeting where we will have an illustrious speaker to be introduced soon. I am in charge of the land acknowledgement. I am sitting in my home on Mercer Island, which was had two villages of the Snoqualmie tribe once upon a time, but the whole area had multiple tribes of the Coast Salish Indians or Native Americans once upon a time, and they all moved around and changed villages and whatnot. So it's a little hard to talk as specifically as you can about in some other parts of the country. So it's more appropriate, I think, to say we are in the territory that once was the territory of the Coast Salish Native Americans.
Well, I think we can all introduce ourselves and our titles and all our accomplishments. I'm Dana Iorio. I'm the vice president of the Pnhpwa Washington chapter. I'm a retired family nurse practitioner.
Hi, David McClanahan, the co-founder and coordinator of our chapter, and I'll be introducing Bill in a couple minutes and also giving some announcements after we've introduced ourselves.
Right, David Loud, retired healthcare worker. My last 10 years worked for Congressman Jim McDermott on healthcare here in the district office. And I'm on the steering committee of our statewide community labor coalition, Healthcare is a Human Right.
I'm Chris Curry. I'm a retired RN in Spokane and member of HCFA.
Oh, I've been around forever, 13 years in rural practice and a bunch of years in teaching, national PNHB for a couple of years. And
I'm Hugh Foy, and I'm one of the co-founders of our state chapter, along with David. And I was a general surgeon and critical care surgeon at Harborview. I worked for the university my entire career, actually, in one form or another, and am also currently on the national board of PNHP.
I'm the resident dentist, retired, been with the chapter, I think since the beginning, but maybe not quite.
Mindy Blasky, retired family practice doctor, and been a member of PNHP since as long as I can remember, probably 20 plus years or something.
Hello, I'm Jerry Ashton. I'm out here in Connecticut, resident also of New York City. I'm a Navy veteran. I co-founded a charity called RIP Medical Debt 10 years ago. As of this last board meeting, we've abolished close to $13 billion for over almost 8 million Americans. Co-authored a book called End Medical Debt. Got some good reviews on that. Handed out a copy of End Medical Debt to every single member of the House and the Senate, and invited them to an evening called End Medical Debt, held in Washington, D.C. I won't say how many showed up, but the beachhead was made. So I am presently focusing on getting medical debt off the backs of veterans. The VA itself holds over $6 billion worth of medical debt through the VA that the VA has refused to honor and to pay. Thank you.
Welcome. Welcome, Terry.
Hi there, Craig Garber, retired neurologist in Wenatchee, Washington.
So I'm a longtime mental health professional who's currently retired because of health issues. And I've been a long time interested in our healthcare system, having been a participant and recipient many years. So I'm hoping that groups like this keep moving on to address the needs that we have, country and culture. And I'm living with a chronic illness. That's why I'm wearing my.
Hi, I'm Margaret. I just talk to strangers about Medicare for All in the grocery line. So my name is Pat Lynch Barrett, and 26 years ago, I started Women's Radio. I also started an agency at the very, very young age of 25 in Atlanta, Georgia, where I have the accent from. And now I'm actually living in Augusta, Georgia. So my background is in public relations and marketing and advertising.
Great to have you all. I think that's everybody. This meeting is being recorded and it'll be available on our webpage, on our YouTube channel. And with that, I'll pass it on to David, who will have some announcements and some other stuff.
Just a couple of announcements, and then I'll introduce Bill. First of all, we heard from John Guyman, who we're lucky enough to get as our speaker for our April 17th meeting, and he's going to be talking about his new book that just came out. I've ordered, looking forward to starting that in a day or two. So I hope to have, his books are easy reading, and there's a lot of information, but they're easy to remember because he repeats himself, which he should and needed, particularly at our age. So at the end, he kind of wraps it up. So you can get these books at Estelita's bookstore. You can order it in Seattle, which is a bookstore that's run by a couple of UW physicians and people who work there. It's a neighborhood bookstore that's very progressive. Or you can buy it on Amazon. We're looking forward to that in a month from now. In the past, we had a March 6th rally at outside our legislature in Olympia on March 6th that had about 12 different organizations co-sponsoring that, and we had 120 people turn out for a 2-hour meeting. Basically, it was support universal health care in our state, and a couple of our champion legislators showed up to talk. Also, Hugh Foy gave a talk for us. Hugh, telling people what is. So we'll be following up with that. I think it was really great to get those organizations together and talking, being next to each other and getting to know each other a little better. And we expect to see some fruits from that in the coming legislative session. That was the last day of our legislative session, which this year is a short one, and the next one, starting next January, will be a long one, where we hope some of the bills that didn't get passed this year will get passed. So I'm really pleased to introduce Bill Bronston, who I've known as family for more than 50 years. Can you believe it? We both still look so young. We met when Bill was living in Harlem working with the Black Panthers, and I was doing my selective service time at the USPHS hospital on Staten Island. And I was involved in anti-war actions at that time, and I guess that's how we met. Bill moved to Staten Island in 1970 to help form the Frantz Fanon Health Collective that we set up in a big house with 4 apartments for our 12 members. And we got into a lot of, quote, good trouble, unquote, providing medical support for the Panthers and the Young Lords, and played a key role in the deinstitutionalization of Willowbrook State School for people with disabilities, which was really a milestone in the Americans with Disabilities Act, but that's another story. So when the Fanon Collective separated, Bill went back to California, where, among other things, he was director of the California Department of Development of Disabilities for many years. In 2004, Bill set up a trip to Cuba for health professionals to see their system, and Hugh Foy and myself were lucky enough to go along on that, along with Quentin Young, who was a Pnhp co-founder. And out of that trip, we set up the Pnhp Washington chapter in 2005 when we got back. The last few years, Bill has been working on the CalCHO legislation, which is the California Lifetime Health Care Act, to provide a single-payer plan for California that he'll be telling us about. So take it away, Bill.
Thank you, David. I'm really honored to be in this group. It was a little bit intimidating because I was struggling last night trying to sleep and trying to think about what had to be said here today, because what I want to talk about is stuff that I really have not had a chance to really talk about fully yet. What I want to say to start with is that the movement for single payer is atomized. There's very little unity, regardless of where you go, around what people are talking about when they talk about single payer. The exact details of that model are not universally shared, and there is not the kind of campaign that would weld us into an ice pick to deal with the problem that we're confronted with. One of the things that struck me was that this work is work worth dying for. And the question that the single payer movement really needs to internalize is, are they willing to die for this effort to humanize and democratize our society, as opposed to allowing it to drift in a very serious way into a totalitarian, fascist, authoritarian, corporate-owned, corporate-driven, alienated delivery system, a medical market system. So that when people talk about health, they're really a misnomer, because there is no such thing as a healthcare system in America, and we should never use the term healthcare when we're talking about what exists now. It is a medical market system, and our language is critical. It's critical because our language is concept bearing. And I want to say again that what we're involved in is a life and death struggle. Every day that we don't change this system, myriad people are suffering and dying. And it is not something that is well integrated and emotionally addressed by the movement. People are working, they're busy, they're involved in what they think is a single payer campaign, but there is no coordination around that content. So a couple of years ago, I invited 30, 40 of my dear colleagues and friends from all over the country in order to craft the most creative, imaginative, single-payer model that we could essentially float as a draft model in order to integrate the concepts into all of the programs going around the United States. There's 17 or 18 states that are working on single-payer campaigns. And so out of that came the concept of a California lifetime care as opposed to long-term care system. The reason why we gave it that name at that point was because in working with the disability community for decades, everywhere where there's disability services entitlements, there is individualized planning in order to deflect people from institutionalization and to maximize their empowerment. The regional center system in California, individual education plans in the school system created by Public Law 145, and with the vocational rehab system, individual voc rehab planning. And so it struck me that we needed to establish a strategy of having individualized planning for every single human being in society to deflect them ultimately from Medicaid-funded out-of-home institutional placement. Medicaid is altogether evil. And the book that I wrote essentially is a tome dealing with the negative impact, the violent impact of funding out-of-home placement, which was a public policy created by the Congress at that time in the face of the Cold War to not Bolshevize the American family by having Medicaid fund individuals in their homes and families to keep them out of institutions. The story about Willowbrook State School is the story of the way in which we were able to coordinate a federal class action lawsuit for crimes against humanity against the governor and the state of New York to close that concentration camp for 6,000 broken people that were essentially there because there was no community-based services anywhere in the state of New York in order to handle people with special needs. The interesting connection is that all of us are going to become developmentally disabled as we age. At some point, we are going to be faced with somehow being served in a multi-generational, normative, image-enhancing environment prior to dying, rather than being put into a nursing home where we have now become 41st in the world in terms of morbidity and mortality. So the implications of our system and the work that we're doing together in order to advance universal single payer could not be more important, and certainly is worth the seriousness to consider dying for, and in that framework, pressing to talk to each other and to talk to other people in the movement in order to clarify and unify our effort. Because when we get serious, we are going to have to raise $100 million state by state, and we're going to be faced with all the money in the world from the major cartels, pharmaceutical, insurance, and hospital cartels, and the richest doctors to fight us and to essentially red bait us. When we're successful, we'll know we're getting successful when they start talking about socialized medicine. So that we need up front to be talking about the fact that we're seriously talking about a population health system that is socialized, like the military is socialized, like the school system is socialized, like the fire department, like the transportation system are all socialized in America. We have a mixed economy, and we need to be sure that we don't allow ourselves to be red baited and distracted. The website that we created, I renamed ourhealth.pub.public. And it's up on the website. And it's also, it's the same thing as the California Lifetime Care Health Act. And so
you're seeing this now?
Yeah.
Okay.
So this website essentially has a homepage, and then there's a list. So it's the team there essentially are pictures and bios of a few, about 2/3 of the people that were involved in this thing, including Walter Tsu, who was the president of the American Public Health Association, and other very, very poignant people. Steve Kemble, who's the other member of the board of Western United States for Pnhpwa and so forth. There is, under the drop down of draft model, there is a set of pieces in there that are summary pieces and comparative pieces between now and what would happen if Calcha was there. Can you just click on it, David, and it should drop down a screen.
This isn't online. This is just a screen.
Okay, all right. So that's where the model is essentially fully text driven, with a table of contents and 10 titles, which we'll talk about shortly. And then over under resources, there is a set of the best books in writing, including all of John's books, John Guyman's books, and Stephen Brzezinski's books. There's probably 25 of the best books in the field that people need to read. So what I want to emphasize again is that what I'm going to show you is going to be a fast running summary, even though I'm going to show you slides that are very, very laden with text, but not read them to you, but essentially just explain what's in those text pieces. But ultimately, this is worth reading. And it's worth talking about, and it's worth comparing to the work that you're doing in Washington, the work that's going on in Oregon, in Illinois, in New York, in California, in Rhode Island, and where single payer activists are going on. So here's the start of the website. Now these slides were made by the woman who is the chairwoman of the California State Steering Committee, a woman named Nancy Grieb. And I did a program for her. And so she went to my website and essentially extracted and summarized and translated each of the pieces down to about 30 slides. So I have about 29 slides here. We're not going to go through all of them. I'm going to slide through some of them, but I just want you to know that it's all there on the website under the drop-down screen called Draft Model. And it's in the middle of that drop-down screen. And I urge you to go there, because this is an anatomy lesson. Single payer is understanding an anatomy of a system more complicated than we are as human beings. that essentially has to be understood, and we have to use the same language for the same bones and the same organs and the same metabolic functions in order to have unity around single payer. And that means that you have to study the goddamn anatomy of single payer, not just in Washington that you've written, but what's going on with Jayapal's bill, what's going on with Sanders' bill, what's going on with the new bill that's just been submitted to the California legislature, Assembly Bill 2200 by the California Nurses Association, which has elements that begin to approach the scope of the anatomy of our health, calcha.org. And I'll mention later on some of the areas that need to be added to that bill in order to make it a true public health driven, comprehensive healthcare system and not just patchwork. Although the Nurses Bill AB 2200, now for the 10th time that they've submitted a bill in California, is really quite remarkable. One of the things that is crucial is that when people talk about making single payer happen, two things happen. Number one, people throw their hands up and say, I don't have the power, this is impossible. The other thing they say is, who's going to pay for all this? What's the cost going to be? Quentin Young was very clear. Healthcare is the only function in our society that has 100% of all the money that it needs to do what it does perfectly. The money is already there. The question is, how is it distributed? And so our position needs to emphasize the savings, the investments, and the prosperity that flows from our policy model. In California, the nurses' bill is not a money bill. The federal legislation, the American ACA, Obamacare, requires that every single nonprofit hospital in the United States produce a triennial report on their catchment area and identify the negative health outcomes and how they're going to deal with them. In addition, it essentially lays out a requirement that any state can submit a policy piece of legislation passed by the legislature and signed into law that essentially would describe a status quo or improved example of healthcare that compares to Obamacare. So we need to be talking about savings, investments, and prosperity when people talk to us about what it is that we're doing, because the benefits to the society are going to be staggering in the multi-billions of dollars if we have a different kind of a system. For example, we need to globally budget all delivery systems. More importantly, we need to globally budget all professional post-secondary health education in exchange for year service in unserved urban or rural medical deserts in order to establish local comprehensivity, cope with the way in which our system has been prostituted by money. When people talk about cost, you have to throw them back and talk about investments, savings, and prosperity. And these items are listed in the website. So the essentials here are we need to take control of the healthcare system from the corporate owners. To decentralize the current profit-driven system, we need to establish universal public health administration of the delivery system. That is not in anybody's bill. The public health system has to be at the top of the pyramid. And there's a state and local level of public health in every state. We need for expanding our workforce is critical. So people say, how in the world are we going to do all this stuff? This is impossible. And my reply is exactly right. However, it's essential. And nothing's worth doing if it's not impossible. It's impossible to have gay marriage. It's impossible to have the end of child labor. It's impossible to have women voting. It's impossible to end slavery and racism. However, we do it. We do it because it's morally imperative. In the beginning of the bill, in the first parts of the pages, I reference the United Nations Declaration of Human Rights, the definition of health in the World Health Organization definition, and the definition of a healthcare corporation in the 501c3 tax law, all of which talks about the strategy to produce wellness, not end illness. What we have now is a system that provides individual medical care and services to individuals, but it is not a population health system. So there's a comparative chart in the website that talks about single payer, nonprofit healthcare enterprises, the leading role of public health, the coordination of social determinants, and another unique aspect of our health. Healthcare has to be delivered by teams, and different teams have to be constructed to address different populations. For example, if you think about what would be an ideal healthcare delivery system in the school system, K till 24, it's completely different than the team that would be required for rural and farm worker health. Completely different from the team required for working with elders, working with incarcerated and decarcerated people, working with the mental health and addiction services. Each of those suffering areas, those areas of wound or service need, require a different combination of professional training, skill sets, and delivery. So one of the aspects that is really outrageously serious is to end all medical debt. Medical debt cripples and wounds the people that suffer under it. In Jerry Ashton's program, he essentially has identified 40 veterans that commit suicide every single day in America as a result of the impact, the burden of medical debt. And what people have to suffer now, the enormous bulge of houseless population in our society is absolutely intolerable. It's wretched that people live in that state. And if we had a universal single-payer healthcare system, it would have to deal directly with ending the poverty and the expulsion of people from housing, and establish strategies to somehow return those people back to normal civic living. Again, the anatomy of our single-payer system has to be the same and shared across the country. And our health essentially lays out the most imaginative and the best goals in order to transform our culture and our society. We are talking about changing America when we talk about single payer. That's why the opposition against this is so wall-to-wall and fierce from the established dictatorship of the capitalist system in our society that allows us a certain amount of flexibility, but at a certain point draws the line and stops the change for a true working class transformation of our delivery system, our society. People are simply caught up in protecting themselves and never imagining that their life is intimately tied up with everybody else around them, regardless of color, regardless of gender, regardless of any other difference about them. So these are the major 10 titles of the model. The model is meant for conversation. It's meant for expansion. It's meant for improvement. So in Title 1, we lay out the notion of eligibility and the 38 benefits that we've identified that would establish comprehensivity. In Title 2, we talk about the financing, the budget, and how payments would be set up. That is not something that has to be in the current legislation. In order to get the waivers needed to bring the federal money home, wherever home is. Title III details the implications of covering these special populations that I mentioned. Title IV deals with addressing the pharmaceutical and medical supply requirements of the system. Title V deals with the need for a majorly expanded workforce development that is culturally competent, that has to come by globally budgeting all professional, medical, health, educational training everywhere in exchange for year service in underserved areas through a national or state health corps. Title VI deals with data. Title VII talks about the relationship to the delivery system to community health delivery. And Title VIII is a very, very complex and very elegant title that deals with the relationship between state and local public health systems and the importance of partnerships with neighborhood assemblies and networks of neighborhood assemblies partnering with local health agencies. The local health department leader, the public health officer at the local level, usually at the county level, would be responsible for annual planning and essentially setting priorities drawn from the monitoring and the role of the neighborhood assembly leadership in looking at and evaluating and prioritizing the transformation of the system, because our system is so prostituted and so utterly alienated that it's going to take time to transform it into something humane and compassionate and tender and loving. 9 deals with the importance of medical research and allocating pieces of the budget for that and innovation. And Title 10 deals with the integration of the Veterans Administration, the Indian National Health Community, and the federal quality medical centers into the system, all of which are single-payer socialist services. So this just goes through the various titles, and it's already 10 to 8. So let's skip this. You're gonna go look and do your anatomy lesson, because you're ultimately politically going to be tested on whether or not you have internalized the anatomy of single payer that's shareable and that is used as a point of unity in terms of our organizing work at the state level and at the national level. So here's Title II about some of the issues of financing and all. Here are the special populations: mental health, school system, rural and farm workers, disability, prison and decarceration. The elder community needs to be added to this, the unsheltered, unhoused, and the care of people with complex, multiple medical needs. So the workforce issue is not addressed in any legislation yet. We must train a new workforce that's not necessarily white, and that's not necessarily male, and that's not necessarily having gray hair or no hair. We need youth, and we need to build that youth in a way that they are assigned to the holes that are everywhere in the system in order to fundamentally create local comprehensivity so people don't have to travel. In Cuba, as a result of the crisis that existed there when the Soviet Union collapsed, the Cuban policy leaders essentially began to organize local comprehensivity in their cities, so that there's a gigantic room in Havana that has a table that's about 20 feet by 20 feet, that has every building in the city of Havana built on that table, in order to look at how people don't have to travel to get to market, get to healthcare, get to school, get to whatever they need at the most local, intimate level within the local blocks. And as you know, the Cuban system is built in such a way that everything is intimately local, so that doctors don't have to deal with more than 800 families. They don't have to deal with an area larger than 10 square blocks, whether that's rural or urban. And they essentially walk the streets and know everybody by first name. And they are known and owned by the general public, who has provided comprehensive educational training for every single health professional in the country. Free, paid for by the general public. Not to mention the fact that they export somewhere between 4,000 and 5,000 doctors a year into the underdeveloped world and have 22 medical schools. The 22nd medical school has close to 20,000 students, not one of which is a Cuban. Not one. They're all international students paid for by the Cuban people in order to go back to their communities to serve the poorest and the most in need people in their societies, including the United States. One of the things we want to do is to end all of the phony costs like malpractice and have a different kind of an arbitration system to work with problems with doctors. But when we get into a system where the people own the doctors, when you have a nonprofit delivery system, politics, accountability will be radically changed. That has to be understood and talked about. We are not talking about the intimate realities of what a true healthcare delivery system looks like, feels like, how it operates, how it works, and how it is morally, essentially framed. The governance structure in our health is much larger than in any piece of legislation. We identified the need for 29 with a minimum of bureaucrats in the governance structure. And so it's all detailed in much more detail, clearer in the Our Health website. There should be a statewide professional and technical advisory council that is where the bureaucrats are lodged and the specialists are lodged. And we need to expand in a very profound way public health in the state and in the country and wherever we have single payer systems. So this is what the state system looks like. And this is just a drawing. There would be 6 independent funds in the single payer budget. There would be a global budget for funding hospitals and clinics. There would be a private provider reimbursement fund to fund doctors billing the system directly. There should be a capital and infrastructure transition fund, a systems development fund to deal with innovative and unusual needs, a public health system fund, and a reserve fund. And until that money is identified, the program would not go into effect. That's where we don't have to deal with the budgetary implications of the system until after we pass the policy legislation to bring the federal money home with waiver programs. California, some of our frenemies engineered a piece of legislation, Senate Bill 770, that creates a campaign to go to the feds to work out a waiver, which is illegal based on the way in which Obamacare is set up, and essentially undermines and sabotages the nurses' bill in terms of when the report from that effort would be made available, which allows the phony legislators that are taking lobby money to say, well, we're waiting for that report to happen before we make a decision on AB 2200. The opposition that we're going to be facing is getting big money. They're aligned in large part with Kaiser, that's scared to death that something would happen if single payer went into effect. But the nurses' bill, AB 2200, makes it entirely feasible to fund Kaiser, but not as an empire, but individually in terms of their delivery system to maintain their integrated services if people want to continue to work there. Here in California, we have 58 counties and 3 cities, and we need to look carefully at how to set up the neighborhood assemblies in each of those counties and how they would essentially be politically representative in the planning, priority setting, and monitoring of the delivery system, which is going to be a tough push because people are not used to serving in that way and not used to thinking about each other as family. But it must be done. And the reason it's not done is because we live in such a rapacious and violently cruel and alienating culture as a result of capitalism. So this is what the local thing looks like. There would be the local neighborhood assemblies, the local public health officer with a neighborhood liaison office, a local professional technical and advisory council, where we deposit the bureaucrats and the specialists, and connected to the way in which the linkage exists with the surveys, the triennial surveys in Obamacare and the local county assessments. And in the Title I of the Our Health model is a whole set of definitions with many, many organizational groupings there, some permanent, some temporary, in order to make the transition happen. So one of the things that is going on here is that there is serious work moving towards reparations. And I submitted this summary of things that if the Reparations Council embraced single-payer healthcare, this would be the benefit to their reparations benefit. So you can read those through yourself here. There's 9 points, very clear. Single-payer would change everything in society, including issues of the climate and issues of poverty and issues of individual isolated alienation. In the website, we have a page that begins to look at the transition. The Nurses Bill, AB 2200, has a lot of transition language in it. It's really worth reading. It's 32 pages long. It's dense and it's very bureaucratic, but it's very, very good. It's not great, but it's very, very good. And so one of the issues that we have to be talking about, which is very inspiring, is to think about how to get from A to B. If we want something to be happening, how do we get it to happen? We're going to need, for example, a whole new crowd of tertiary teachers at the post-secondary level to teach the next generation down of what healthcare services are like, not to mention the need for funding and transforming the 41 million unfunded caregivers in America that are essentially taking care of dependent members of their family and being pulled out of work. They need to be paid. More of the conversion issues of what has to be addressed. These are not done well. It's much clearer in the bill, in the model. This essentially takes us back really to the beginning of the presentation in terms of the moral foundation of what we're all about. We need to build that anatomy so that it's transferable and shareable in detail and understood and testable. Getting rid of long-term care is critical. It exists everywhere, and people do not understand how corrupting Medicaid is. It's corrupting. It makes permanent poverty that keeps that dependent population out of meaningful roles in contributing to the economy of the society. The whole need to integrate the coordination of social determinants of healthcare, food, transportation, housing, education, work, all the things that are essentially resulting in huge injury in terms of mental, behavioral, and emotional health in our society, which is just devastating going on right now, has to be looked at and discussed in our groups as part of the plan to construct the anatomy of the single-payer system that becomes the foundation for building a broad, unified, inspired public support. This is one page that just kind of summarizes the situation. Again, this is the anatomy of the model for discussion. All this is largely agreed upon, but not detailed. We still don't have a shareable anatomy of single payer between national Pnhp, the nurses, us. And we're going to have that if we're going to build a campaign to address the cartel opposition, because it is going to be fierce beyond imagination. If you think that trying to not get Trump elected is going to be any different than getting single payer to happen, then we really have a very serious challenge in our hands. Okay, that's it. You have to read and you have to get very disciplined about the anatomy of single payer and how you share that with anybody else who says that they're a single payer advocate. I'm open for hammer blow criticism.
Well, that's like amazing, but it's like so locked. Like, I don't know how you talk to people. It's like overwhelming, but it's like totally fabulous.
It is overwhelming. It is. We are faced with an overwhelming challenge, Mindy. It is absolutely impossible to do what we have to do, and that's what we have to do.
Okay, so we're going to have a question and answer period. Thanks for your very comprehensive talk, Bill. You've certainly raised some eyebrows, and I'm sure there are some questions.
Let me just say one thing. We won't know whether we're effective until they start red baiting us. Then we know that we're making it happen.
Let me just say that these slides were comprehensive and dense, but you can, if you let me know, I can send you a copy that you can have on your computer or print out or whatever to go over it in a leisurely fashion.
Go to the website. The website is much more interesting and much more articulate and more beautifully written. It was written over a period of a year. We met every single week for 2 hours, 40 of us, with all the experts you can imaginable. The website's really good, Our Health. Download the nurses bill, AB 2200, and start looking at that, because that's the most advanced model apart from Jayapal's bill, which is clean and remarkable. I don't know if Jayapal has a number yet. Anyway, go ahead.
Okay, Pat?
So you may have covered this, but I didn't see it. So one of the issues that I've learned about firsthand is the real lack of knowledge about health that's being taught in the medical institutions. And it's almost like it's deliberately left out. There are people who are trying to help put it back in there, but it's at a snail's pace. What are your ideas about being able to retrain the doctors, basically, and give them information about health and bring the health and research part up to speed?
It's got to be built into any bill, and it's got to be the foundation for the challenge to PNHP as a role model and to APHA as a role model. You're exactly right. The doctors are alienated, and they've become essentially proletarianized by the corporate ownership. The doctors are bleeding with burnout and alienation. They're constantly having to deal with a computer between them and their patients, and they're constantly having to bill for everything they do. It's killing medical services. And healthcare is not for sale. It's not available. It doesn't exist. Healthcare doesn't exist. It's not a commodity to be bought. All that's there is illness management, period. Unless you're talking about the public health system. So I just organized a YOLO chapter of PNHP that's all public health leaders, including the dean of the School of Public Health, 25 of the master's students that they have in their system there, in order to begin to trumpet the public health message into PNHP, which doesn't deal with that yet.
I have one question for Bill. Great overview, really way out there. Let me ask one question about hospitals, which, as we know, they fund almost 2/3 of physicians. They're highly coordinated, very difficult, huge hospital systems. Some of the early people that started with PNHP, including David Himmelstein and Stephanie Wohlhandler, and several of us put together a paper a year or two ago. We were trying to see what the big problems were, and they came down to say, after all that, since 1987, that hospital ownership is a big deal. So how would you address that?
It's in the bill, John. The way we would deal with it is through global budgeting. The hospitals have to be broken apart. They have to have an annual budget that would be quarterly paid. They would have to justify what they're doing based on a foundation that would start when the program began, after it began, and it wouldn't start until we had enough money in the system to not have rollbacks.
How would you get to that point?
Organizing. We need to reach hundreds of thousands of people somehow. I mean, that's the kind of role that Pat Lynch is involved in, is setting up campaigns in order to use mass education through podcasting and other kinds of media. There's no magical solution here. The reason why things are as they are is that money has replaced people in our society. One of our positions for PNHP is people over profits, not profits over people. And so however we have to deal with that, I mean, the question that you're asking is a critical question that has to do with how we feel about our ability to address these impossible challenges. But we have no choice if we're going to continue to do this and we're serious about it, other than just saying that we're kind of progressive and we're on we believe in single payer. We have to deliver it to the people. It is a life and death matter, and we have to deal with it as a life and death matter when we're talking to each other. It's got to be dealt with fervor and conviction and courage and outrage. I don't know what else to tell you, my dear brother. I mean, that's the problem of being our age. We only have a short period of time in order to role model. But we need young people that are fierce. When we were organizing students, when I put together the student health organization, we had 10,000 killers across the country that were fundamentally challenging our medical schools to change their curriculum, supporting the civil rights movement, and opposing the war in Vietnam. A lot of that happened. I mean, the schools really changed. I mean, the pressure that the progressive students, smart, articulate, fierce students, nursing, medical, dental, public health students, med tech, all in the same organization. Teams, not vertical doctors on top of everybody. So it's doable. It just requires leadership, vision, and conviction.
Okay, David Loud.
All right, thank you. Bill, thanks very much for the presentation. The website, could that be put in the chat?
Ourhealth.pub, David. It's super simple. Our health, one word, .pub.
I wanted to tell you that the Pramila Jayapal's bill, the current bill for this congressional session, is H.R. 3421. Now I have a question. Could you expand a little bit more on the controversy, the problem with Senate Bill 770?
Yeah.
Okay, could you expand on that a bit, please?
770 was written by a guy named Michael Leidy, who is the devil's handmaiden. He organized a phony coalition called Healthy California Now in Northern California, and he's essentially undermined Pnhp. He's undermined the Democratic Socialists of America. He's undermined the Japanese progressive single-payer movement. He's undermined Healthy California for All in the state of California with his effort to essentially alienate around that bill. That bill became proposed as a solution, like Trump is saying, Biden never won the election. Leidy is saying that 770 is going to solve the problem of single payer with the federal government. But he is absolutely being funded by the wrong side. And he was removed from the nurses organization and removed from Bernie Sanders' organization precisely because his role was putting in phony loopholes in all those legislation bills in order to allow Kaiser to maintain their capital situation. 770 has been detailed. I can send you, I'll send David McClanahan a bunch of papers written by Ash Kalra, the author of Single Payer, and the nurses organization, the details, the critique of 770. And when the final bill came out, amendments were put in that Leidy put it in there that made it even more onerous. And so the deadline for a report is sometime in 2026 or 2027. The nurses bill comes up in June or July of this year. And so the progressive, the liberal Democrats, we have more than 2/3 Democrats in both the Senate and the House here, essentially are saying, well, we have to wait for that report to come out before we can take a position on AB 2200. It's just so subtly evil. It's evil. And there are members of Pnhp that Hugh is aware of that essentially have aligned with Leidy, and it's a very bad situation, very bad. The national Pnhp has discombobulated, has disorganized the statewide California steering committee of Pnhp because of this conflict over 770. And we're still in that situation. And so we're going to have to go head to head with the national. I mean, there's a very serious problem that's going on here. I've never experienced before. It's ugly. It's really ugly.
Okay, so yes, please do send the critiques to Dave McClanahan so he can share it with us.
I'll definitely do that, David. Thank you very much.
Thanks, Bill. That was great. I've heard it before, but I understand it better as time goes on. I think it is truly transformational, and I am hopeful. The one specific thing that I've been looking for, and maybe with this gathered audience, particularly maybe John Guyman, you might remember, but I put this in the chat. I had conversations with Quentin Young and Fitzhugh Mullen that there at one time was crafted legislation to establish a more robust U.S. Health Service Corps, both national and international. I have looked through all of the bills, Conyers, McDermott's, Sanders, Jayapal's. I cannot find it anywhere, and I can't find anyone who can lead me to it either. And so do any of you know, A, did it truly exist? And B, where can I get a hold of it?
I don't know.
Because the idea, and I think Bill addresses that, I think that, we have to have immediate, short, and medium and long range goals. And one of the long range goals, of course, is that we have no health workforce planning coordination at all in this country.
Right.
And John, you've had extensive experience with the AAMC as a former department chairman. And I looked all through their stuff. Nowhere at all in this year's annual meeting did they address any of these significant issues. It was all so ethereal and practical. So if anybody can find any of those specifics, because I think we truly need that aspect, because single payer insurance plan, as you point out very well, Bill, is just part of the picture that needs to happen. But the whole picture needs a societal transformation.
That's right.
And with the control of the media, I don't know how we're going to do that.
Yeah, I don't know if anything was contained in the Dellums bill back in the early 70s that proposed a national health service, but I think that dealt with some workforce issues in healthcare in general. So you might look up the Dellums bill.
Okay.
To see if there's any information you can glean from there.
Where was Dellums from? Do you remember what state?
Berkeley.
California. Yeah, Ron Dellums, right?
He became the mayor of.
All right, good. That's a good lead. Thank you.
Also, call David Double and Stephanie and see if they have any memory of that.
To Jim McDermott, because I saw him give eulogy to Abe Bergman when Abe Bergman, who was a very activist pediatrician after Abe died. But I don't know if you read Robert Reich's article. McDermott's hiding out in the south of France because he's worried Trump's going to come get him, which may be a rational fear, as a psychiatrist would say.
So, Bill, you mentioned how fractionated the single payer movement is. First of all, I'd like you to define what you consider the movement. And second of all, do you have any ideas on how we can cement a little more solidarity between all the different fractions? And a lot of it has to do with state single payer versus federal. So do you have any ideas on how we can just get these movements together and working on what we all know what we need to do?
That's why I put Our Health together. I was hoping that document would be the tool around which to build conversation and unity. The question of fragmentation is that everybody believes in single payer, like they believe in giraffes and they believe in buffaloes and they believe in gorillas and they believe in lions, but it's not the same animal. And everybody has a different notion of single payer. And if you start to talk about single payer, there's all this but, and all this variation. Nobody is clear because it's not clearly in writing, and people haven't read Jayapal's bill, and they haven't read Sanders' bill, and they haven't read AB 2200. They haven't read the damn stuff. They have not done the anatomy lesson in order to take the test. And until we're serious enough, given the life and death implications of what we're all about, to read the shit and then to fix it if it's not fixed, and to use it as a way of essentially building community. When you talk about people endorsing single payer, they don't know what they're endorsing. They don't know. I mean, it depends upon what's in their head, and there's no way of setting criteria. And as Mindy said, this is complicated. It's really complicated. because it touches every element of our lives. Every element of our lives essentially is impacted by what would be a true population-based healthcare system. That's why we need public health leadership to articulate what it is that's needed in terms of delivering health care, wellness, and empowerment to a society. Your question, these questions are absolutely on the mark, but that's part of the problem is this total lack of discipline and rigor in our communities. Like DSA, Leidy has removed the healthcare issue from DSA nationally and at the state level. The whole DSA caucus for single payer removed themselves from DSA because of Leidy's manipulation. I mean, this is really serious. I mean, we got to start talking about people. We got to talk about the politics of what's going on and the lack of rigor on our part. Everybody is happy about being part of the movement, but they're not willing to die for it, and they're not willing to go to the wall to deal with it. You know, we just had a major set of meetings on the 16th and 17th of March that the nurses organized called house parties that were held all over the state. I had one, you know, and the purpose of that was to prepare people to support 2200, not so much with the legislature, but to reach out to the general public with crowd outreach work. So I'm planning to do, you know, work like you all are doing in front of markets and in various places, but you have to have a document. And the problem is the document is so bloody complicated that to summarize it and have it on 1 or 2 pages, or to have a strategy of how you're going to have people do the same thing that will essentially put them into the same relationship to one another is really an organizational challenge of the first order.
Big time. So you're saying we just need a really big mass movement to push things forward.
We're going to have to go to a direct vote at some point. There's no question about it, because even in California, if we passed the bill and were able to get the waiver, which is nothing more than a promise, we would then have to go back to the California legislature for a financial piece of legislation that would probably require tax increases, because there would be no other way to compensate for the small gap of money that would exist. That would require, you know, a proposition, because the legislature would never pass the bill to increase taxes on people. We're going to have propositions in states that have that possibility. I mean, it's a dwarfing situation. I mean, there's no question. I know, but what choice do we have? What choice do we have? You know, somehow we have to mobilize and get out of the comfort of being single payer advocates and become single payer activists.
Dr. Bronston, what states are currently friendly or considering any portion of this program? What states do you consider to be states that we might gain some traction in faster?
Washington, Oregon, New York, California. I know there's about 15 or 16 other states, but I don't know where they are in terms of their progress. I know that Ohio is working on something because of Weisbart. You know, I mean, there's work going on everywhere. In Maine, wonderful. A fellow by the name of Phil Caper is working on the Maine single payer campaign, but I don't know who's got legislation. And the reason why they don't have legislation is because there's not unity. There is not unity. There is not a document that we all agree on, we stand on and say, this is worth dying for, this piece of legislation, and we're going to be there with that kind of tremendous conviction and moral imperative. I mean, we're in a very, very early phase of mobilization. Not that we haven't been doing this for 50 years. All of us have been doing this for 50 years. Nevertheless, we haven't made a movement to mobilize the kind of numbers that we did when we did Prop 186 here. The first time we did a proposition in California in 1994, I mean, it was incredible. We had the whole state organized, and had we had more time and an extra $2-3 million, we might have been able to push it through. But it was writing that document that changed everything. Until we had the document, people were blowing smoke. They were talking and arguing about this or that and various different elements of the program and the campaign, all essentially exhausting people's ability to do anything. They were talking about everything and not doing what needed to be done, which had to be, you have to put this in writing. Once it's in writing, you have a hammer, you have the ice pick.
New York has the New York Healthcare Act that Pnhpwa Metro chapter in New York has been pushing for quite a while, and I think they've made some progress.
So they deal with long-term care. They have not looked at the problem of Medicaid, and Medicaid is totally. I mean, here's the issue: Medicaid essentially has been seen as working primarily for people with developmental disabilities. The fact of the matter is that as we get older, we will become developmentally disabled in our old age. And we will be forced into poverty by not having more than $2,700 worth of assets in order to be eligible for Medicaid. And we will be essentially put into congregate segregated, dehumanizing, depriving, unsocial environments. Read my book, read Public Hostage, Public Ransom, Ending Institutional America. It's everything I understand. Everything I understand. It took me 50 years to write that book. It's heavily illustrated and it's ferocious. And it lays out the whole foundation for the need for single payer healthcare all the way through from the beginning and the evil of Medicaid. And talk about it. Talk about it. I mean, we need to get deeper into doing something about what we believe in and understand the gravity of what's at stake.
Could you elaborate on the evil of Medicaid?
Medicaid is set up to fund facilities. That's number one. And so you've had $6 trillion spent in Medicaid dollars since its inception to institutionalize America. You know what that means? Nursing homes everywhere, supported living everywhere, hospice everywhere. 70% now owned by private corporations, underfunding the mostly diverse workers, mostly women that are staffing those programs on a shift basis, and essentially resulting in 40% mortality as a result of COVID because of the congregate segregated situation. And Medicaid makes you poor, keeps you poor forever, and forces you into an institution. I believe that all of us need to be, and never in a congregate segregated facility of devalued people. And as elders, we are stigmatized and stereotyped as devalued because we're no longer part of the workforce. It's a beautiful book written by a woman by the name of Bolton called Health Communism that deals with this. And it's just a slim little book produced by Verso Press, Health Communism by Marie Bolton. And it's just a terrific book. And you should have her in your meeting to talk about her book and about her thinking. She's brilliant. The fact that we don't know, or that most people don't know what Medicaid is in and of itself a manifestation of the weakness of our movement. We need to know that stuff cold. We need to be able to talk to ordinary people about the problem that they're faced with, that they're going to wind up in institutions. That's why I wrote my book. That's why I wrote Public Hostage. It starts off, the first half of the book is about Willowbrook. The second half of the book is about the ransom. The ransom is Medicaid. And all of that is essentially fraudulently used in order to fund the ownership of the institutional system, not the workers, not the people that are incarcerated. It's evil. It is utterly evil compared to Medicare.
So, Bill, have you submitted your CALCHA plan to PNHP National, and have they looked at it and made a comment about it or considered that for a national plan?
The answer is functionally no, Dana. I mean, Hugh's there at the national level. David's been there at the national level. I mean, I'm sort of a black sheep. I mean, somehow or another, people don't deal with what I do. They deal with that I've done it. And I didn't do this. 30 people, 35 people did it. It's really good. It's really good. Mm-hmm. And it's a policy model. It's not written as legislation. It's written as a policy model for people to discuss wherever they are, to look at how it fits into A, their lives, and B, their work, in order to expand. There's so many elements that are in that are not in any of the legislation. For example, the whole emphasis on prosperity, investment, and savings as opposed to cost. The need for public health leadership, the need for globally budgeting post-secondary professional education, the need for eliminating medical debt, the need for changing long-term care to lifetime care, the need to integrate veterans administration and Indian health, the need to decentralize the hospital empires to return back to home and neighborhood services, the need to essentially build in a heavy commitment to PR, media, and social media as a crucial element in any single payer campaign in order to move the people with us. The whole campaign to look at the charity industry. The charity industry is double taxation. It's all double taxation. And the majority of it is in administrative stuff, not in anything real. All those charity organizations, breast cancer, mental retardation, all of it, it's all administration. We wouldn't have to have that if we had single payer. The whole charity movement would evaporate if we had single payer healthcare. I mean, the implications are immense what we're talking about here.
So I would need my GoFundMe page. Huh?
Well, look at what we're down to. I mean, we have to go and beg strangers to help us deal with something that was legitimate, that was needed. The problem is that we have this wall-to-wall racism in our culture, this caste system. I don't know whether you've seen or read the book Caste by Isabel Wilkerson. Brilliant, incredible book. And they just made a movie, DeBardet made a movie called Origin, about her writing this book and about her discomfort with seeing racism as the problem as opposed to caste consciousness, looking at India, looking at South Africa, looking at Germany, looking at the slave period in the United States. I mean, there's some deep, moving, inspiring ideas out there that we're not talking about and building into our strategy to frame the anatomy of our single payer organizing tool that will bring together millions. It has to bring together millions through the organizational movement, not one at a time. Churches, Black Lives Matter, Me Too, Never Again, Poor People's Campaign, all of that. We have to go to those organizations with a coherent, consistent anatomy of our proposal in order to get them to learn it, to understand the anatomy and be ready to be tested on it with their people in order to move those multiplier, to move those people to change.
Okay, any further questions for Bill?
I'm very grateful for your time and your patience and your understanding. And I just hope that the recording will get to more people than we're here.
I want to thank you very much. And I do want to say one thing. For many years, I have been trying to explain the difficulties and complexity of this. I've tried to tell people, first we need a commitment to a single payer system that covers everybody. And that then creates a platform upon which we can construct a better healthcare system. And that may be a somewhat easier way to explain it to general public, who, if we showed them your slides, they would fall over in a heap because there's just too much to absorb for somebody who doesn't know what we're talking about to begin with, as compared with all of us, who of course know so much and are still kind of like, after looking at all of that. But I just kind of like the image of a commitment to single payer, single system that covers everybody. And that's a platform upon which we need to build a better system. And then when people say, well, I'm from the Poor People's Campaign and poverty is our main problem, then we can say that needs to be built in to a better system. It has to be a more comprehensive social services system that includes healthcare as part of it, which is, I think, what you're trying to say.
I don't think you have to tiptoe into William Barber. I think you go to him as Washington State and you tell him that you're battling here to put together legislation. that you have a strategy and a model and you'd like to develop partnerships with him in order to open up a conversation between Washington and the Poor People's Campaign, not between Weinberg and the general public. You're absolutely right, but I think we need to use our organized machinery as a way of building partnerships so that we leapfrog, numbers.
Okay, I guess I'm just thinking in terms of people I meet at random at some social.
Sure.
They say, "Well, what are you doing in retirement?" And I say, "Well, I'm advocating for a single payer healthcare system." And they say, "Oh, that's a great idea." And then they move on to other things.
It's not just single payer. I think you're advocating for a healthcare system that would transform their lives.
Right, right. But the conversation has to at least get past that before
Sure,
I
understand.
put out the idea of it being a platform with a better system built on it. Because you scratch the general public that we run into in social environments.
No, I totally understand. You've got to take it from where people are and where you are. You make your choice about how you're going to open the conversation, inspire people, and get them with you. But then you have to have something that they can join.
Yeah, right. Okay, well, thank you very much. It has been a wonderful session, and I'm so pleased to see you all, and especially John Guyman and Emily, whom I haven't seen in a couple of years since we had dinner together in Friday Harbor. Another time. Don't forget, everybody, in 4 weeks on April 17th, I think it is, we will be having John Guyman talking about his new book. Until then, thank you very much.
Thank you very, very much.
Thanks, Bill.
I'd say that this new book of John's is really critical for this upcoming year with our elections and,
Yes.
the situation in Congress here. And I think we all should have that book and read it by the time John gives the presentation.
How do we find it, John? How do we find it? We go to Google or we...
Corporate Power and Oligarchy, and then there's a bunch of other stuff there. But in Seattle, you can get it at Esalitas bookstore, or anybody can get it on Amazon.
Thank you very, very, very much.
Okay.
Thanks, Bill.
Bye-bye.
3, 2, 1, 0.